Hello everyone, welcome to another lecture for drug delivery engineering and principles. I am Rachit and I am going to talk to you about route specific delivery that we have been discussing in this course. So, a quick recap of what we learned in the last class. In the last class we learned about inhalation, continued our discussion on inhalation. So, one thing we talked about is what is the right particle size for deposition in deep lungs. So, if I plot it on the x axis, let us say if I say particle size, and on the y axis if I talk about fraction that is depositing, and this if I define for deep lungs, which is our major concern when we are talking about delivery. Then what do we get? We get so we will get something of a curve like this, where we see that anywhere between 1 to 5 micron. So, this is micron, we get quite a high deposition, and anything above that we do not get much deposition in the deep lung, anything below that we also do not get much deposition in the deep lung. So, this is the optimal range for let us say polymeric particles, and I will come to that again in a moment. And we discussed why this is the case. It is an interplay of 3 different forces: the gravitational sedimentation, the inertial impaction, and the Brownian motion. And it just so happens that the velocities that we deal with the lung, this size range helps in better deposition. So, this is deposited, sizes in this range are exhaled out, and sizes in this range are stopped at the upper respiratory tract. So, that is what we discussed in particle deposition based on size. Then we looked at nebulizers as one of the methods for lung delivery, and this involves using some power to generate mist, and it works very well in the hospital setting. Again, you can generate this mist in the size range of 1 to 5 micron, and it works very well in the hospital setting, but in the patient compliant department this fails quite a bit, just because the patients will have to go to the hospital every time they want to do this. And then we discussed dry powder inhalation, which causes first of all stability, because these things are in dry powder. And then not only that, this is very patient compliant, and which is fairly obvious, right, because the patients can actually inhale this themselves. It is not a very complicated procedure, it is well accepted by the society as well. So, there is no stigma attached to it either. So, this is what we discussed, and then finally we discussed how we can play around with these dry powder particles if we are using particles in those cases where we can engineer the particles to, instead of having a solid matrix, if let us say if it was supposed to be a solid matrix, then I would have required 1 to 5 micron of the actual diameter, but what you can do is you can actually make a bigger particle, but instead of a solid matrix, you have a very porous matrix. So, very loosely bond, and that then is starting to play around with the density of this particular particle, and because of that you can then increase the size range to let us say 8 to 10 micron and still have the same effect. So, that is what we discussed. Then we talked about buccal administration, and in this one we were saying that this is very similar to the oral route, where you still have to ingest the drug, but when you take it through the oral route, you do not have to actually let it go all the way down to the stomach. You can just put it under the tongue and keep it there. So, what is going to happen is whatever the mucosa is present under the tongue will cause the absorption of this this route. And what we also did is from the buccal cavity. So, all the stomach and the intestine, whatever is absorbed goes into the liver and then it goes to the systemic circulation. So, if this is systemic circulation, however, from the buccal cavity it does not actually go to the liver, it directly goes into the systemic circulation through another vein. So, that prevents this metabolism by the liver, and that way you can have much higher drug being in the systemic circulation compared to what you would have got if you would have taken it down to the stomach. So, however, there are again challenges associated with this. First of all, how do you get the drug to stay at that site for long, because it is very uncomfortable for the patient to keep a big tablet under their tongue and similar things. Then we also talked about rectum administration. So, just like the buccal cavity, even in this case it also bypasses the liver and directly goes to the systemic circulation through another vein, and this is another advantage. It is fairly rapid, but then again there were some challenges associated with. The biggest of them is again patient compliant. It is not very useful if the patients are not going to agree to this. So, that is a problem. However, with children and babies this could still be used, because parents can easily administer this without worrying about damaging the tissue, without worrying about finding a vein, which even for a trained personnel can be very difficult. So, that is some of the advantages why this is still around compared to some other routes. Okay. So, let us talk further about different routes. Today we are going to talk about another mechanism, which is intra-articular administration, and as the name suggests, this is injection into the articular joints. So, knee joint is one of the articular joints which is one of the major applications for this administration. So, you can take the injection and directly inject into the joints. So, it goes back again to what we had discussed, that it depends on the application. So, let us say if you are trying to treat osteoarthritis of a knee, then it does not make sense to inject everything into the whole system, because what you will find is if you inject 100 milligram into the whole system, less than a microgram will actually go to the cartilage, just because cartilage is not very well vascularized. So, you may want to directly inject it into the joint. Obviously, this is a very difficult injection, can't be done by anybody. There is a big risk of these needle can actually damage your cartilage. So, it should only be done by trained personnel. Then you would need an intervention by going to some hospital or something, but even then it is much better because most of the drug will then localize into the joint, and you can have much higher joint retention of the drug compared to if you inject it in IV or intramuscular or subcutaneous or some other site. So, an example of this is Zilretta, especially the bioengineering example. So, again you can inject quite a lot of things in the joint, but joint also suffers with a similar challenge that it has a good lymphatic systems. So, if I actually expand on the joint capsule, so let me just actually draw a joint. So, let us say this is femur, which is nothing but this bone, and this is tibia, which is this bone here, and then you have cartilage which is lining these two bones, and then this is actually being encased by something we call synovial membrane. and this whole system is called the joint capsule. Now that you have this joint capsule surrounded by the synovial membrane, this synovial membrane is actually very well vascularized. So, lots and lots of blood vessels, and along with the blood vessels it also has a good lymphatic system. So, now if you inject anything in this joint space, that drug is going to get absorbed into the lymphatics, into these blood vessel, and get cleared out from the joint. So, what you find is, even though you get a much local delivery and still quite a high concentration for a little bit of time, most drugs typically within few hours, 3 to 4 hours, they start to decrease their concentration significantly in the joint space, and at that point you do not really have much controlled release. So, whatever you are injecting is going to get released out fairly quickly, and the joint space will be empty of the drug within a day or so, if the drug is fairly small, which most drugs are in this particular example. But so, going back to our concepts that we have learned in this course, we can engineer biomaterial to have a longer residence time. So, what is typically seen, that if you increase the particle size or the drug size, that will have a much longer residence time, because now that the drug size is so big, it cannot really go into the blood vessels, it can't really go into the lymphatics very easily. So, that is what is being used here. So, in this particular product, which is Zilretta, which is already again out in the clinics, the whole concept is to use about 35 to 55 micron PLGA particles, and because of that because these are so huge particles that they can't really escape out. Even the immune cells which are of the order of 10 to 20 micron can't really clear these PLGA particles away. So, now you have created a depot in the system. So, this PLGA particle is going to sit in your joint space. Of course, it needs to be compatible, so it does not damage your cartilage itself, but this is going to sit there, nothing can clear it out, and the only thing that is going to happen is it is going to start degrading and releasing whatever it is encapsulating over time. So, in this case the encapsulated molecule is this acetonide, and it is a short acting corticosteroid which is used to decrease the inflammation as well as help with the pain. So, it gives you a very long lasting pain relief for more than 12 weeks. So, a single administration is enough for you to get relief for 3 months. So, it becomes very patient compliant in that regards. And then what this particular particle is engineered with, it is engineered with 500 nanometer channels. So, here is a graphic of a particle that the company is giving, the Zilretta, that you have these depots inside these particles of the drug, and then the drug then slowly comes out through these 500 nanometer big channels that are present. So, as the particle degrades, more and more channels open, more and more depot of these drugs come out, and that helps in the pain relief for this particular joint. Okay. Next thing we are going to talk about is intravenous delivery, and this is again by far one of the most used methods in the hospitals. There are several advantages to this. The drug is immediately 100% bioavailable. So, the moment you inject it, it is in the circulatory system, it is going to immediately distribute throughout the body, and it is going to be immediately bioavailable. Remember, when you say bioavailability, it is basically when the drug is able to access wherever its target are. So, once it is in the blood, it can go all over the place in the body and it will be bioavailable. It is very rapid response, again goes back to the same point that it is immediately available. So, it can act on its target much more quickly, and a very rapid response is seen. So, if a patient is actually suffering from, let us say, a condition in which if something is not done within few minutes the patient may die, then IV is the route to go. You can't really wait to inject it intramuscularly or subcutaneously and wait for 10-20 minutes for the drug to take effect. You want the drug to take effect immediately. Maybe it is something that is causing the heart to stop, and you want to give some biomolecules that may cause pumping of the heart to begin in a normal scenario. So, in that way the IV is the best route to go. you have a total control on the concentration. And this is important because again even though you might be injecting somewhere intramuscularly subcutaneously and you think all of that is going to go to the blood, but then there is a whole kinetics that as the things are building up in the blood they are also getting excreted. So, you do not really actually know how much is the peak concentration you are going to get in the blood at a time, even though you might have done some experiments, but it will vary with the site to site you inject. So, all of that variability is still there, but in the IV injection you know that whatever you injected is immediately in the blood even before it gets eliminated. So, you have a fairly well control of what your pharmacokinetics is going to look like. Immediately you will have a certain blood concentration and only then it will start to drop out. You then also maximize the incorporation of degradable drugs. So, what that means is whatever drug you are injecting is immediately getting incorporated into the blood system, whether they are degradable or not. Going back to the point that if you inject it intramuscularly subcutaneously, they might start to degrade even at that site, and again you do not know how much of the concentration in the blood you are going to get. And since not everything is going to pass through the liver, you bypass the first pass metabolism. And here are just some examples. So, what you are looking here is bolus doses of injections are typically given. You have, I am sure you all of you must have seen these IV bags that are being infused to infuse maybe some fluid into a patient or maybe some drug into a patient. So, these are very traditional forms of delivery that are extensively used in clinics. What are some of the disadvantages of the IV injection? So, first is of course is extremely invasive. We all have gone to injections, it is painful, we do not really want to get an IV injection unless we have to. So, that is a major challenge. The second is not everybody can do this procedure, we can't do it sitting at our home, we need some trained personnel to be able to find the right location of the blood vessel in which to inject it. You do not really want to inject it in a site which is not correct, you do not want to damage a blood vessel either multiple times trying to find a blood vessel. So, it has to be a trained personnel who can do this. And then there is possible toxicity due to incorrect dosing. So, let us say if you do inject it trying to inject it in the blood, but eventually having injected only some in the blood, some in the surrounding muscle, you are doing some incorrect dosing and it causes toxicity. And not to mention that you have to be extremely precise with the dose, because it is going to build up the concentration in the blood immediately. So, if you do end up going to the toxic level, it will cause toxicity. And of course, one of the major challenges, the sterility is also very important. So, if since you are directly putting in the blood, you are giving, if your injection is not sterile and it contains let us say some pathogen or some infectious agent, you then actually put it in the systemic circulation, which means that that pathogen has access to all parts of your body. So, if let us say the pathogen only infects lung, it will be able to go to the lung as well, because all blood goes to pretty much every organ that we have, and that is a big problem. So, it is a very stringent sterility maintenance that should be followed before doing the IV injection. That is why you see patients before they get anything they are swiped by an ethanol wipe or something to sterile the area as well. So, even if let us say your drug is completely pure, but maybe your skin carries some pathogen, even that gets removed off. Okay, so this was basically mainly on the traditional form of delivery using IV injections. What about more on the bioengineering aspect of it? So, here is a diagram showing how various aspects of the blood that needs to be considered when we are looking for the delivery through the blood. You have seen this before. So, what it is let us say you are injecting some dose into the blood, you have a circulatory system. The first thing that is going to happen is heart, since it is pumping continuously, it is going to start pumping whatever you have injected in the blood to all parts of the body. And so, I have only shown few organs here, but it will pump it to every part of the body. The smallest capillaries that we have are about 5 micron. So, which means that if you inject anything which is bigger than 5 micron, what is going to happen? Let us say if I inject this particle which is about 10 micron, it can flow through this big vessel, no problem. It can then start to diffuse in and bumped into the small vessels, still it is okay. But as it goes down to smaller and smaller vessels, it may just get lost there, because it is physically too big. It has really no way to go because it can't move forward unless it ruptures the blood vessel. It can't go back because the flow is pushing it forward. So it may clog this vessel. Now if this vessel is going to your brain, then basically we are talking about stroke, because suddenly a part of the brain is not receiving oxygen, the cells will start to die, and as the cells die your brain will stop functioning, a part of the brain will stop functioning, and that will lead to stroke. The same thing can happen in the heart also. Similarly, if one of these vessels is feeding the heart cells, then and that suddenly stops, then you are talking about a heart attack. So it is a very serious problems if you inject something which are bigger than 5 micron. So definitely you will not be able to inject things which are bigger than 5 micron. Then the other organ we already talked about quite extensively is liver. Now liver, as I had already mentioned, is a metabolizing organ for most things, and it lot of the blood does pass through the liver. It is a fairly large organ, and so it will metabolize quite a bit of your drug when you inject it into the circulation. And not only that, the liver cells are actually very good in sampling anything foreign. So the blood vessels in liver are actually lined with this Kupffer cells, which are the resident macrophages in liver tissue. So these resident macrophages keep on sampling whatever is flowing. So if there is just the blood cells or our body's own cell, these do not really do anything, but when they find any foreign particle or pathogen that is flowing through this, they will engulf it and try to kill it. So that is one place where you lose quite a lot of your particles. And again, since I said it is macrophages, and we discussed in the inhalation part of the things that macrophages do have fairly high uptake between 1 to 5 micron, and in fact even then even we can even say that even from 500 nanometer they will start to clear things. So now we said we can't have bigger than 500 bigger than 5 micron. The other thing we are saying is even at 500 nanometer we will get some clearance. So ideally we want long circulation, we would want to go below this size. Now let us talk about another organ. So here is kidney, and this is in the very early part of this course we discussed that kidney can clear anything below 6 to 10 nanometer. So that means if my size is less than 6 nanometer or 10 nanometer, it will have a very fast clearance from the body, because this kidney will continue to filter it out. So that is again something that we do not want, because if you want a long circulation, we want to make sure that not everything that you have put in goes out through the kidney. So you want to make sure your particles are greater than 10 micron. So now we have already said here we are saying less than 5 micron, here we are saying greater than 10 nanometer. So that is one limit. Now we are saying that the liver will also take out 500 to 5 micron, even though with not very good efficiency, but it will still take them out. So ideally if we really want long circulation, we are talking about 10 nanometer to 500 nanometer. And now another major organ is the spleen. And so what does spleen do? So the blood, and we have discussed this before, so this is a bit of a repetition, but the blood that comes into the spleen actually gets filters out in the spleen. So most of the blood empties itself in the spleen and then goes back into your blood vessels. Now these blood vessels are comprising of all these endothelial cells and all kinds of smooth muscle cells. So they create a pore size here which is about 200 nanometer in a healthy person. So if now you have anything which is greater than 200 nanometer, it will be very difficult for it to go through this. So what will happen is that will start accumulating in the spleen, and the spleen is rich in lots and lots of immune cells, and they will come and start gobbling these cells, these particles up. And we discussed previously that if you can play around with elasticity so that it can actually become soft enough so it can squeeze through, but in generally speaking this 500 nanometer is now becoming 200 nanometer, because again if you have particles between 200 to 500 nanometer range, they will tend to be cleared out by the spleen. Okay. So, these are some of the major limitations that have been put by our body's internal healthy organs that we need to take care of when we are looking into IV delivery using some biomaterial based particles. Of course, you can't put any macro device, so that is completely out of the question since it has to be less than 5 micron, and then further if you want long circulation it has to be within this range of 10 nanometer to 200 nanometer. And then finally, we have in this particular example I have also given a tumor here, and it has been described here, and we will go into a lot more detail of this in this next slide. So, let us look at more on the tumor environment, and we have also discussed a bit of this, but what tumor is an organ which was never supposed to grow there. So, is this extra mass of cells that have come in which body had never programmed. So, if you look at healthy cells or healthy tissues, let us say if this is a healthy tissue, then pretty much every part of this tissue is being fed by a constant supply of very regularly arranged blood vessels. So, these blood vessels have been growing as we were growing and the tissues were growing, and they ensured that pretty much every part of this tissue is well vascularized. So, even the widest differences between the two blood vessels is never more than few hundreds of microns. So, maximum 100 micron maybe. Now, this is for the healthy tissue. However, when you compare this to a tumor tissue, the tumor was something that body had never programmed for it. So, the blood vessels have never really tried to grow into the tumor tissue, but what is happening is the tumor tissue is inducing blood vessel growth, so that it can get nutrients while it is growing. So, when you look at, let us say if I make a diagram of a tumor tissue, you may have certain regions which have high density of blood vessels, and then you may have regions which have really no blood vessels. So, I mean all of that area is now relying on these blood vessels to feed them. Now, that is a big area for things to diffuse into. So, what does tumor do? It causes the blood vessels to dilate, and these blood vessels are formed also very rapidly. So, they are fairly immature, and so what I am basically getting at is this diagram, where if you see blood vessels in healthy tissue, you see them lined very well and fairly mature with some very basic amount of gap between these cells. However, when you look at the tumor blood vessels, these are fairly immature and they are fairly leaky. So, you can find that there are actually gaps here which are 100 to 200 nanometer big. Maybe these gaps are about only 5 to 10 nanometer, but these gaps are huge, and because of that if you now design a particle which is let us say 50 nanometer in size. So, while that particle is flowing here, it is just physically too big to be able to go into your healthy tissue, whereas in the tumor tissue these particles can very easily diffuse out and go into the tumor within the tumor cells. So, because of that we say that these tumor vessels have enhanced permeation. So, this is called enhanced permeation. And then the other thing which is shown here is lymphatic vessels. So, similar to that, the lymphatic vessels are not very formed. So, the major job of the lymphatic vessels is to take extra fluid out from the system. So, since the lymphatic vessels are not very good, you are getting fluid accumulated in the tumor region as well. So, obviously these blood vessels are putting pressure on the tissue on this direction. The lymphatic, since it is not there, so there is a lot of water which is putting the pressure on the tissue in this direction. So, because of that, whatever particles that come in are not able to then diffuse out from this tumor. So, there is pressure on this direction, there is pressure on from this direction. So, these particles have nowhere to left but to get retained in the tumor. So, this is called enhanced formation and retention. And this is not only for tumor, if there is a inflammation at certain place, then that causes a lot of immune cells to go, and very similar to the tumor there are lots of cells in the surroundings. So, they also have their vessels dilated and they also are slightly leaky. So, this works with both the enhanced formation retention will be seen in tumor and inflamed tissues. So, to be ideally speaking, anything below 100 nanometer will be able to utilize this effect to a very nice extent, whereas anything above 100 nanometer may be difficult. It may diffuse into certain areas, but not through all areas of the tumor vessels. So, ideally you want to have your particles anywhere between 10 nanometer to 50 nanometer if you are trying to target these tumor inflamed tissues. Even up to 100 nanometer is okay, but beyond that it is not going to work very well, at least with this concept. So, that is what people then do. Then when they make these particles for tumor application, and you will find them quite a bit in the literature, and we will go over some of the examples, they will use anywhere between 10 to 100 nanometer. So, we will stop here and we will continue further in the next class. Thank you.